Then it's an honor and pleasure for me to call Professor Zakс, who is for anti-VEGF therapy under real-life conditions.
Dear colleagues, ladies and gentlemen, I have the pleasure to be here and to give a talk about anti-VEGF therapy under real-life conditions. And the reason for the real-life study was that we saw in our cohort, or in the German cohort, a situation which was really not acceptable for us all. So there was the reason that we saw the vision declining after anti-VEGF therapy, and we wanted to come closer to the reason for that. So I give you a short overview. The study design is always a problem in real-life studies because it's retrospective. I show you some results of our things that we elevated there, the examined parameters, the analyzation of the subgroups, and give some discussion, maybe some relevance of that what we saw. This is from the registration studies, something we all know. That's the curve when we do anti-VEGF therapy like under study conditions. So we have a gain of visual acuity, and this is something we want to keep, but in real life conditions that's what we don't have. So there are some international real life study. One of them is the AURA study, which compares different countries. And this curve is different to that what we've seen in the registration studies. So we have a primary vision gain, and then we have a decline in vision. So the question is, why are the graphs in real life different? Why is this visual gain transient? And what are the possible reasons for that? So when we look to the chart from this AURA study, which compares more than 6 countries worldwide, you see United Kingdom at the top, and what you see here are the data from Germany, which did not make us happy, because what you see in this column is that we lose the visual gain. And what you see here is that we only do very few injections in comparison to the United Kingdom. And there should not be a reason for that. But we were looking for the reasons of that. So it's quite clear that the more you inject, the better the performance is, but there should be some reasons why the performance is that bad. So the less injections or examinations like OCT, the worse the results in the study. Do we have a different framework or different conditions than the United Kingdom? Or do we treat different stages of the disease? May we have more advanced AMD cases in our real-life population? We all know that it's problematic to translate these high injection numbers and examinations into daily routine, or are there other reasons? When we look to this German data from the AURA study, there is something in particular we have in the region where I am working in Saxony, because we were able to inject according to label without restrictions from a certain time point on, because there were good contracts with the caretakers. And so for that reason, our regional data could differ from the German data. That was something we expected. And we wanted to look whether there are differences to the AURA data, and definitely for the reasons of that. How our real-life study was as follows. We had 850 patients with about 1,055 eyes, about 10,000 injections. We were looking to 12,000 OCTs, and we had about 25,000 visits. This is an enormous amount of data. So, when we are looking to our data, then we had a visual gain in the first year of 1.3 letters, and you see that we are losing the visual gain over time. And that's not like in these registration studies. And if we compare it to the German Aura data from this international comparison with 420 eyes from Germany, we had more than 1,000 eyes, then we had more injections in the first 2 years, 8.5 to 5.6 in Germany. And the visual score was light better in our data than all over Germany. And in the second year, we are going below the baseline. And if you look to these big studies like CUT, where we have the prospective study situation, then you had about 12.6 injections over the first 2 years, and you had a visual gain over the time. So, when taking all our data and putting it into a graph, you see a situation like this. That's the first year, and then we go through the baseline in the second year and still losing again. The data of 5 years it's always a problem because the numbers getting quite lower here in terms of statistics. But that's the shape of the curve. And if you compare it with this international data, what you see here is the dotted line, the German data, and this is the UK data. And we tried to fit our data into this chart, so we have to reschedule it, and that's what you have in our situation. And this is not really much better than what this real-life data in the rest of Germany is, but we had definitely no restrictions to give these injections. So what is the reason for this curve? So we were looking to the population. What's the age? Are there different stages? Is there maybe a scarring, atrophy? What's the baseline? What's the infrastructure? What are the efficacy of our procedures, patient management, and so on? And another thing was that we wasn't thinking first on is how was the access to therapy, and more important, what's the influence of the adherence to the therapy. So back again to this chart. We are looking for the reasons. One, maybe we treat more advanced cases. Now, we took our data and we're looking to, do we have in this data a subgroup with a better visual baseline? Yes, and there is a subgroup with better visual acuity, and this subgroup shows a better preservation of visual acuity. What happens there? So that's the old data again. The curve below is of these persons which have a better visual acuity at the beginning, and it really is a different graph. But if you look to the numbers, these patients beginning with the better visual acuity have more injections. That's simply a fact. And you see the letter scores here that they really seem to do better. So what's the result of that? Yes, there are facts that play a role in the visual acuity development if you look at them alone. So the real-life patients are always a mixture of different patients. Cases with therapeutic intervention is sometimes borderline within these patients. So all these patients reflect the totality of the treated patients, and that may be one of the reasons for the difference in the results. So yes, obviously it's possible within this data to have patients with higher injection rates. Does the access play a role? Or does the adherence play a role? First, to the access. I told you in the beginning that we had the situation that we had some restrictions in the beginning, and then the caretakers opened the situation so that we could give these injections like the company suggested to do the injections. So we were looking for these time points, and we're trying to figure out what this makes a difference. And this is what you see here. That's the curve you already know. And if you make a startup at that point where we had no restrictions at all, the rest of the curve seems to look different. That is what you see here. So if there are no restrictions, then the patients do better. So the access obviously plays a role to the outcome. And one more, does the adherence play a role? We were not really thinking of adherence in the beginning, just doing the injections, but we all know that the PRN scheme requires visits every 4 weeks, which is quite a lot for clinical situations. But how regular do our patients visit us? In a prospective clinical trial, the study patients who do not come within this scheme are sorted out. These are protocol violators. So you don't have these patients in this set, what you see in the registration study curves. So, one more. Oh, here we go. I'm stuck a bit. No. So, how regular are they really in the clinic, our real life scenario? And we saw only 30% were able to keep to a visit interval below 40 days. And even then, in these patients, the average fluctuation is rather high. It is 20 days. So this is not really a situation that we wanted to have. So does adherence play a role? The data clearly indicate that the visual acuity preservation is better in the 30% of the patients that strongly keep to their visit intervals. So now the next chart. What you see on top is still the old curve, and that is what you get when you look to these 30 patients who really come regularly. And what you see here over 5 years, they seem to keep their visual acuity. So this is much more similar to these studies which they do for the registration of the medicaments. So obviously in our patients are patients who run like in these registration studies. So how good is our therapy really? Are we able to improve something? Yes, I think we are. These were PRN data. We use now the treat and extend scheme, and that reduces the number of visits and enables a more individualized therapy to the patients, and it improves the understanding for the patient. So if you compare all these charts now, then what you hear is everything. What you hear is in the middle, the patients with the high visual acuity in the beginning, but they still lose. And that's the patient who are really compliant. So compliance seems to be the major factor. So our real life data are principally good comparable with all the other real life data. We have big data and we have subgroups which clearly see where you have higher injection rates than average comparable to the registration studies. The group has a better baseline visual acuity than the average. It indicates less advanced AMD stages and therefore better comparable even to prospective studies. But this group is not the winner. This group has not the good long-term visual results. Independent from the good baseline visual acuity is a group with good 2-year results, where the decline in visual acuity is less prominent. This group is characterized through missing dropout, through strict following the visit intervals, and therefore is similar to a population of prospective studies, and not selections in the baseline data. So our conclusions: prospective studies differ from real-life data. Different stages as baseline, different adherence. Missing adherence is a classical dropout reason in prospective studies. These patients are missing in a prospective study. Despite this difference, similar results in prospective studies are possible in daily routine. More than the baseline data, the adherence to the therapy is an indicator for long-term success to anti-VEGF therapy. So it is our goal to improve the patient's adherence, and that's our main mission. Thank you for your attention.
Thank you very much. The paper is open for discussion, please. Any questions? What is better, Avastin or Lucentis?
All the studies show that there is not a real difference. I think one major point is if the access to Avastin is better, then I would choose Avastin. It's like you do in the US. If you have to pay for the drug and you cannot, then it's more easy to do it with Avastin. So if you have the situation that you are not injected, that is always worse.
Other questions, please.
Do you also have data on Russia? About,
no, I'm sorry. No.
But anyone from the audience? Is there any experience or study about the VEGF treatment in Bashkortostan or Russia?
So we are able to have the labeled drugs, so there was no Avastin in our charts at all.
Okay. In real life, what is better, Avastin or Eylea? If you had the disease, what would you like to get for you?
If you would ask me Avastin or Eylea, I think I would choose Eylea. Eylea, but it's mainly a reason that it's a labeled product. You can rely on it, but at that time where we had the medical legal situation that we had Avastin, I would have chosen Avastin at that point. It's not a problem, it's just a medical legal problem.
Other questions, please? We have a bit time. Please.
Спасибо за что дали возможность задать вопрос. Хотел бы узнать, при каких заболеваниях используете лечение препаратами в вашей клинике, кроме ВМД?
The question was in which diseases we use this medication. Okay, we have a situation which is legal in Germany to use it in diabetes, to use it in uveitis, to use it in vascular occlusion and in myopia, and there is the other situation, the off-label use in seldom cases. But that's the labeled use, and we all use these drugs in these situations. There are merely no restrictions.
Other questions, please?
Я правильно понял, что вы сказали, Авастин лучше, чем Луцентис?
I hope I did not say that. So Avastin is not better than Lucentis. If you compare big data, then Avastin, Lucentis and Eylea do not show any significant advantage.
Local
So it's
effect.
the same. It's the same.
Local effect is same, yes? Local effect Avastin and Lucentis is same, but system effect.
I didn't get the translation right now, but I think you meant whether one is more safe than the other. Is that correct?
Yes.
Okay. No, I don't think so. There are some theoretic data that Avastin may have problems to the pigment epithelium. But in the clinical setup, this has not been shown widely or in a significant situation. So that's more theoretically. So if I had to use it, Avastin, I would not have any problem using the Avastin. Not at all, not in my mother. It's a good drug.
Thank you. Но мы знаем, что Avastin подавляет свободный VEGF фактор в плазме крови 3-4 недели.
You are addressing the systematic. If you compare the drugs, the Lucentis has less systemic influence because it vanishes very fast. So from this point of view, there are factors, even in Eylea, which leads to a higher systemic exposition. But the clinical data don't show that this is a problem. If you look to the heart attacks, things like that, it's no difference at all. But you are completely right, and this is a good question, and this is always something which is under investigation. Lucentis seems to be the drug which is less in the system.
Thank you.
Other questions, please? Nobody leaves the room without a question. Clinical situation, one eye is lost by AMD, the other eye has advanced drusen and pigmentary irregularities. Would you give prophylactically an injection every 6 months into the last remaining eye with a high risk of conversion?
I wouldn't do that. It's a question of doing examinations, but not of prophylactic treatment.
Okay. Any other question, please? Okay, thank you very much.